Hello and welcome to the Great Birth Rebellion podcast, where we grapple with current research to help you get the best out of your pregnancy, birth and postpartum journey while still challenging the dominant birth culture. I'm your host, Dr. Melanie Jackson at Melanie the Midwife, and I'm joined weekly by my co-host B from Core and Floor Restore, and this is the Great Birth Rebellion. Welcome everybody to episode 7 of the Great Birth Rebellion. My goodness, do we have a treat for you if we could have even peaked after last week's episode. But B, I've also got some amazing news. I got a text message yesterday from a friend saying, "Oh my gosh, congratulations for being in the paper." And I was like, "What? We're in the paper?" She's like, "Yeah. The Daily Telegraph has listed the Great Birth Rebellion as number 9 in the top 10 new podcasts."
So thank you to all our listeners. You are legends. We love you. We adore you. This is really cool. I can't wait to see where we go. All right, let's get Hazel. We just want you to talk now because you're incredibly, very excited. Oh no. I'm going to mute myself.
I haven't even said Hazel's here yet, B.
Did I just spoiler alert?
Spoiled it.
Hazel, I don't even know Hazel. What are you talking about?
Well, okay, I went to all this effort to get a very special guest, and B's just like taking the lid off the box and out pops Hazel.
She's popped out. You popped out of a vulva cake with all your epicness. She's laughing. She's just muted, so you can't hear how awesomely funny she is.
I'm going to introduce our amazing special guest who B just let out of the bag. So we are going to talk about birth after cesarean today. And I've got Australia's biggest expert in this because Hazel, she's laughing again. Hazel, I know Hazel well, and I'm going to introduce her a little bit based on what I know about Hazel, and then Hazel, you'll need to fill in the gaps for me, but let me see. So Hazel Keedle, currently Dr. Hazel Keedle, because she's got a PhD, works at Western Sydney University as a lecturer and researcher, has 5 children, is that correct? Yes. Woman who herself has had a VBAC, also has a history as a midwife in lots of different settings, rural, including home birth midwife, lives in the beautiful Blue Mountains, has just written a book called Birth After Cesarean, likes gluten-free, has to eat gluten-free food. Hazel, did I leave anything out?
No, that's pretty good. So 3 of my kids are bonus children. And so I had the two babies who are no longer babies. One is 15 today. It's his birthday. And the other is nearly 14. Yeah, and we just have those 2 at home now because the other 3 have all flown the nest.
Magic. And I could not recall the name of your PhD thesis today when I was...
Oh, what was the name of it? Women's experiences of planning a VBAC in Australia.
Right. Amazing. And that's what we're going to talk about today is birth after cesarean. And before we start, I need everybody listening to listen very, very carefully because you too, B, she's just shuffled up close to the screen.
I'm putting my only good ear that works because my other one's deaf. Okay, go.
Listen up, B. Okay. I went to Hazel's book launch last night and I bought 2 copies of Hazel's book, Birth After Cesarean. One's for me and for my library for my clients. The other one is for the listeners. And what I'm going to do is for those who are on the mailing list, and if you're listening to this on the day that the episode lands on a Monday, I'm going to send the mail out a bit later today so that everyone has a chance. So listen to it. Then I'm going to send out the email to the mailing list, and it's going to have a question on there. The person who emails me back with the answer first gets a copy of Hazel's book, Birth After Cesarean, and I will personally post it out to you. So that's my challenge to you, listeners. If you've binge listening and you're listening to episode 7, in 2044, you've missed out.
Anyway, I want to hear all about Birth After Cesarean. Let's go. Sorry. I have a question, but I know Mel's got a plan. Mel's always got a plan. So you go for it, Mel, and then I'll chime in when it's the least appropriate and ask my question.
And I particularly love how Hazel's the guest and we're yet to give her an opportunity to talk. All right, we are going to head into our questions. And the reason we position this podcast so close to the beginning, I suppose, is that one of the big things that's super important for women who are planning their next birth after cesarean is if you get to 37 weeks and realize you haven't considered something and that maybe you're in a position where you haven't got the best team behind you, it can sometimes be too late to find the right people to be with you to really achieve your goals. We want to encourage women that if you have had a previous cesarean section and you really want to change things for the next time, the time to start doing your planning and thinking is before you get pregnant with the next baby. So that's why we've kind of positioned it soon, is we would love to make sure women have that information before they get pregnant. So here we go. Hazel, I'm just going to launch in with these questions. If I was a woman and I had had 1, 2, or 3 cesareans before, why should I consider planning a vaginal birth for my next baby if I've had previous cesarean sections?
Well, what we do know from my PhD research is that women actually want the option to have vaginal birth, and vaginal birth is important to women. But it's often downplayed. It's often, especially once you've had a cesarean, you have that age-old incorrect belief that once a cesarean, always a cesarean, and you don't even know that it is an option. But then women that are wanting to plan a VBAC, they're doing it for a range of different reasons. There is the actual desire to have a vaginal birth, but there's also practical reasons, because a cesarean is major abdominal surgery, and at this point they've got at least one other child to look after as well as a baby coming along. And yeah, women, we're smart. We know that if we've had another cesarean, that's going to limit how much we can pick up our children, how much driving around we can do in that first 6 weeks, and how difficult it will make it to be caring for a newborn plus your other children as well. And so often women are choosing to have a vaginal birth after cesarean because they want a better healing time. They want to be up earlier, and they really actually want a better birthing experience. As much as some people say that women don't want to have vaginal births, that's not what we've found, and that's not what we found in our recent survey either. It's actually that over nearly 80% of women actually said that a vaginal birth was either very or strongly important to them.
And the recent Australian Women's and Babies report showed that only 12% of women are actually having vaginal births after a previous caesarean section in Australia.
Yeah, VBAC is in the minority. So when women have had a previous cesarean, and those stats are population data, so it's looking at all the women in that year that had a previous cesarean, and then what type of birth did they have. And so yes, we sit around 11 to 12% of women who've had a previous who have a vaginal birth after cesarean. There's then usually a couple of percent of women who have an instrumental birth, and then the rest are cesareans. They don't tell you in those stats how many planned to have a VBAC and had a repeat cesarean, but most definitely, the actual group of women that have a vaginal birth after cesarean is quite small, and that's only for a VBAC after one cesarean. If we start looking at VBAC after multiple cesareans, then that number drops another 10%.
And I've read a study recently by Cox in 2015 which was about VBACs at home, and the percentage of women who were able to have a vaginal birth after cesarean at home was heaps higher. I can't remember the exact stat. I don't know if you know that off the top of your head.
So we do know that there are some things that increase the VBAC rates. So first of all, just to get the numbers correct, and I've just done a session with my students actually about VBAC, and we broke this apart as well, is that with our population data, we only know the mode of birth that happened. We don't know what the planned group was. And so in that group of women who had a repeat cesarean, there will be some women that planned a VBAC but had a repeat cesarean. And I'm very careful about language. I write about that in the book. I won't use the term success or failed or trial of scar or trial of labour, because we're not in the court and women are not criminals. But they planned something and had it, or they planned something else and had something else. I don't use the emotive language. So it's difficult from the population stats to know how many of those planned a VBAC and had a VBAC. And yet when we then look at numbers such as the one from from Cox is what we're looking at a group of participants or subjects that actually we knew what they planned to begin with. So then you actually end up with two cohorts. You have the group that are planning a VBAC, and then you have a group that are planning an elective cesarean. And then where they get that higher statistic from is then from that group that are planning a VBAC, they then look at how many of them had the VBAC and how many of them had a repeat cesarean. And so that's where we'll get the general percentage that without impact of model of care or place of birth, about 60 to 70% of women who plan a VBAC will have a VBAC, and about 30 to 40% will have a repeat emergency cesarean.
Which is in line with current statistics of a person having their first baby, right? So we've got around in Australia, roughly 1 in 3 women will have a cesarean and 2/3 will have a vaginal birth. So that's a person having their first baby. So it's kind of always from the data I've looked at being very similar to that.
Absolutely. So then in the study you mentioned, they look at out of hospital birth or home birth, and that's where we then get a higher than the norm. So if we say the norm is maybe about 60%, obviously it varies by different studies. Then if you add in there a different model of care or an out of hospital setting, then that goes up to 80% plus. So it does show to you that women are not changing. I mean, there's some slight demographic differences, but actually the model of care and the place of birth has a bigger impact on VBAC rates.
So then what we see then is approximately 12% of women here in Australia are having vaginal births after cesarean section, but we're not really sure about what their preference was at the time. Of a cohort of women who intended on having a vaginal birth after cesarean in hospital, approximately 60 to 70% of women will do that. And then if you go to the next sort of tier up, where you've got a woman who's chosen to have potentially a home birth or in a midwifery model of care in a bit more of I don't want to call it boutique, but, very specialized kind of model of care, that rate of vaginal birth after cesarean could go up from 80% upwards.
Yeah.
It's really interesting. Yeah,
absolutely. And so even in that population data with that 12%, that could still have been about 60 or 70% of women had chosen that. We just don't know that because we just don't ask that question or measure that question. And, I said, what questions do you have? And some of the students said, well, our hospital says they've got like a 70% VBAC rate. And I said, well, you can get that out of 10 women. So, they actually may own that. That doesn't mean that it's particularly great if they're only offering it for 10 women and 300 are not being given the option and are having repeat cesareans. That might just be the really 10 determined, difficult women who are saying, I'm going to have a VBAC regardless, and 7 of them had one. So, I was trying to break down on what that means and how to understand that in their own hospitals too.
Yes, and historically women were told once you've had a cesarean, you need to have a cesarean for all of your next babies. But that's not true.
No, that was based on when cesareans were big zipper cesareans, like they weren't the transverse, they were the longitudinal straight down the middle. And a large proportion of the uterus was cut to be able to get the baby out. But nearly I wrote about all this in my PhD in the history section. It was a really long time ago that they actually introduced transverse scars and from that, or transverse cuts. And from then onwards, that saying of once a cesarean was a cesarean should have been thrown out with the dinosaurs, but it stayed around. And unfortunately, women may even be told after their first cesarean that not to have a VBAC or not have a real understanding of why they had a cesarean, and then they leave the maternity system and they're out in the community, and this is kind of some of the information that they then get given.
And just to clarify, just in case people don't understand, what Hazel's talking about, that in terms of transverse cut is what the majority of people having a cesarean section today have. It's that cut from hip, in terms of from side to side. So it's not from your hip to your hip, but it's going transverse, so sideways across the body near the bikini line. Whereas what used to be done a long, long time ago, and it was cutting up and down. So basically from the ribs to the pubic bone, not as big, but in that direction. So vertically down your body.
Yeah. There's a lot of variety in between that. So if people are unsure, there's a great group called Special Scars, Special Hope. And they're actually set up, they're a group of women who've actually all got something a little bit different about their scars. So sometimes it can be an extension, it can be a J, it can be an inverted T, it can be a previous uterine rupture. So there can be lots of different ones. They've got a whole list on their website, and then they actually have a Facebook group as well. And I mention them in the book because they've been amazing supporters to me in the past. And
what are they called again?
Special Scars, Special Hope.
Oh, that's awesome. I've never heard of them. That's amazing.
Really good. They collect data, or they don't collect data, but they look at the research that's out there, and they support each other. And they have like a closed group as well for women who actually have that information or have that history to support each other as well.
Yeah, epic. Mel was saying yesterday at your book launch, you were talking a lot around gathering the right team for your birth, and you use the analogy of like an Olympic team. And I'd love you to explain that. And I, gave the analogy, which I often give around doulas with Mount Everest. It was like, okay, so you're at the bottom of Mount Everest and you're telling me that you really want to climb it and you really want to get to the peak. And your partner is there and you want to take him with you because he really cares about you and he really supports you and he says he wants to be there. But you get there and he's saying, let's get on the helicopter. Let's get that helicopter. Let's get on that helicopter right now. And my analogy of a doula is always like a Sherpa. The Sherpa knows how to navigate Mount Everest. A doula knows how to navigate birth. And the Sherpa is saying, no, we can do this. I can get you, I can get you on that journey that you want and help you, try and reach the peak. And I can see how people might be triggered by some of the language I've used in that. So apologies if you are, but can you explain the birth team analogy that you were talking about at the book launch yesterday? Because I think it's epic.
Yeah. So the big thing that came out of my PhD was that there were 4 factors that impact how women feel after having a birth after cesarean, regardless of what type of birth it was. And they are control, confidence, relationship, and active labor. And so when I write about relationship, that's about the team that you have around you, your healthcare providers. So in that chapter, I kind of start off with when I was writing it, and it was during the Tokyo Olympics. And I was really inspired by, obviously all the stuff that was going on about it. Especially in the Paralympics, which I really love watching. And it made me think, these athletes that train so hard to get to the result of hopefully winning a gold or a silver or a bronze or, just beating their personal best, they have a very carefully selected team around them. They have that coach that, and you see that relationship with the coach. And so they have this amazing team. They have people that care for their physical health, that care for their nutritional health. Then they have this coach that is almost like that project manager and keeps a tab of everything and really believes in them. And then they go through it. And sometimes the coach takes the spotlight in that particular case. But most of the time, the coach is sitting back and enjoying the fact that their athlete got to do what they really want to do and supported them in that way. And yet they might only do that, like the big Olympic races, they might only do that a few times in their lifetime. And women generally in our country, we generally do that a few times in our lifetime, but we do not invest as much in our team for something that we will remember forever, and we will remember how we were treated forever in the same way that we would do in Olympic sports. And sport is important, that's true, but once they finish being an athlete, they go on to something else. When you finish having a birth, you go on to be a mother. That's a really important role to do, and it's something that we should really be investing, that we've got women in the best possible place to be. So then I kind of challenge women and I say, well, what kind of coach do you want? Do you want the coach that, when you interview, say you're interviewing for coaches and you want to do that 100-meter sprint, and that's when you want to get gold, and then the coach says, well, yeah, you could do that, but I think you probably have a heart attack halfway through. Like, I think you're just going to drop dead. Like, everyone's going to die. Like, what is the point of doing that? Or if you don't die, then, you're going to break your leg on the way and you're not going to be able to walk any better. And what's even the point? What are you going to get from it? What is the value of even doing that race? like, why don't we just watch it on the TV? It'd be much safer for you. Just be a bystander. You don't need to take part. Like, how are you going to feel at that point? Your hope and your dream is that you're going to get to that race or to have a vaginal birth, and this person's saying that you're just going to die, and what's the point of doing it? Or would you go for a coach that goes, I believe in you. Like, I believe in you, and I will do everything I can to support you. I'll get the other team around. Let's do this together. And I know that you can do that. And I see you at the end. And whether that's on the gold or the silver or the bronze or beating your personal best, you are going to feel amazing. And I'm going to do everything I can to support you to get there. And you will feel amazing regardless what happens. And I'm going to support you. Like, that's who you would go for. Yet in maternity care right now, and certainly in the VBAC survey, 50% of women in the standard care received hurtful comments during their pregnancy. And those hurtful comments ranged from not believing in the value of vaginal birth, so not believing in the value of the race. Why don't you just watch it on TV rather than taking part? Why don't you have an elective cesarean rather than planning a VBAC? So they're not even believing in the value of it, all the way through to threats of death to themselves or to their baby. So your baby will die if you plan this. Or one of the most hurtful quotes that I read in the survey was a woman being told, if you plan a VBAC, your husband will end up with a dead wife and a dead baby and a toddler to raise on his own. That is coercion to the extreme. But women get that. 50% of women receive those hurtful comments of the variety that is there. Mm. So why would you choose to go with that person? Or why would you go, yeah, I'm going to choose that person who threatens everything and doesn't believe in anything I go for? So that's kind of where I get the analogy from. It's like, why would you want to choose the best team around you? And certainly from the research that we've done, that is constitutive care with a midwife and then everyone else, and that would certainly include a doula.
So firstly, Hazel, I mean, I just want to send love to anyone that's ever had anything spoken to them ever that wasn't anything but supportive, because if this is you listening to this and this is bringing up lots, I just want to send you love. Secondly, I love all that you're saying, and it applies to all birth, not just vaginal or birth after cesarean. It really does, and it's what, Mel and I bang on about all the time. Thirdly, I always say to people, you will never, ever regret investing in yours and your child's health. And I often throw questions about it, how much did you pay for your car? How much did you pay for your wedding? To really put it in perspective of money for a care provider that's right for you. D, I think that's what we're up to. I just want to acknowledge that not a lot of people get choice in Australia, and that is a huge, huge barrier to everything in maternity care services. I've worked a lot, and I know you have too, Hazel, in rural and remote areas, and there's even in the cities, like the amount of women that say, I tried to get onto the midwifery program and I couldn't, or they wouldn't accept VBACs, or they have a VBAC. I spoke to a woman the other day and she said, yeah, they have a VBAC clinic, and I was like, great, what does that entail? Has that got continuity of care? No. Didn't have anything. It just meant you had to see this, it actually meant more doctor's appointments. That's what it meant. So I just really want to acknowledge that a lot of you listening to this won't have choice. So this, looking at what else you can do if you are having publicly funded care and the person that is, your coach keeps changing at every appointment. Mm-hmm. And one time your coach is really supportive and the next time the coach is telling you that you're going to die if you have it, because that's a reality, right? A lot of women in Australia get fragmented care. It's really hard in health, because it's, whilst we have guidelines and we have policies, people bring their experience and their opinion into care, which is how we end up with coercive care. And so there's not this, everybody does this and everybody does that. It's very, with the care and opinions and evidence that you may receive in one hospital can be very different to another based on the person giving them to you. So in terms of recruiting a team, I mean, my biggest thing here, if you're birthing in a system and you haven't got continuity, the best way to do that is with a doula.
It is very challenging, because, we then look at women that have the resources, because they're able to do that. And so if they're able to either have a private midwife in their area and then to be able to afford that, or to be able to find a doula and then to be able to afford that. Unfortunately, we don't have very many community programs where doulas are provided. But we do have a growing midwifery group practice. And we're seeing that in the models of care that, maybe about 30% of women are able to access that now, and it is growing. But it is important for our hospitals to keep that growing. So if it's getting to a point where you pee in a stick, you get a positive test, and you have to book your MGP midwife, or it's too late, then all that shows is that you need to grow that. You need to have more midwives there. And certainly if they don't offer VBAC, then I just think that's nuts. Like, I don't understand that, because women who are planning a VBAC just want to have a physiological birth. And the professionals who understand physiological birth and supporting women through labour are midwives. Doulas absolutely on the side, but as healthcare professionals, that is midwives. That's what midwives are trained to do. I'm an educator. This is what we do at university. Yes, they understand all the complex stuff too. They understand when things aren't going towards a physiological birth or need more assistance or need collaboration. But these are the experts. And so to think to even exclude that from a continuity of care program, I just think is nuts. Like, I challenge people all the time.
But if you're pregnant right now and you're wanting a VBAC, you know, I think, like, what I love to do is give practical tips for now. And so often they've got barely anything at their fingertips. Like, you and I know, yes, of course, that's what all women should have access to midwifery continuity of care. There's enough research that supports it in all areas, from the amount that it costs to the benefits for mum and babe. So yes, obviously continuity of midwifery care, but the reality is many women aren't getting access to it. So what can they do to assemble?
Well, I think first of all, see what is in your area and ask around, and ring up your local hospital and say, what models of care do you have for me? Because often they're there and maybe they're not being advertised to you. Maybe your GP doesn't know about them. So first of all, ask, like, ring them and say, do you have a continuity of care model? If you don't, then ask, do you have a student model? So we have all of our students in Australia, our midwifery students, have to follow through 10 women all the way from their appointments, on being there for their labour and birth, and postnatally. And some universities encourage the students to find out people on social media, so you might see adverts, but others only recruit through hospitals. And so they might say, that's right, we have students here. We've got a student who's looking. And believe me, our students, they really want to follow through VBACs. They love supporting women planning a VBAC. And like I said, today we did a whole session on VBAC. They know exactly what to do and how to support you. So that's another way. And certainly in this survey that I'm working on now, the Birth Experience Survey, we've seen comments about the benefit of having a student midwife. So right now, that could be a practical thing to do. If you've got enough time for them to see you 4 times, which really, you're going to be having weekly appointments anyway towards the end. So that could be you a month out of labour and birth. Can you find a student to support you? And that's someone else that you will get to know and has knowledge and growing knowledge through their course about supporting women. And then another factor is, are there doulas in your area? Are there doulas that are attached to particular programs? Are there student doulas out there if you have limited resources? So there are other ways that you can look at, how could continuity look for you? There are some women that actually really enjoy continuity of care with their doctor. And what you have to be aware of is any bits of baiting and switching, that they might be really pro to begin with and maybe a little bit unsure at the end. But certainly there are some amazing doctors out there as well that provide continuity of care. So I wouldn't want, if a woman's got a fantastic obstetrician and is really happy with them, to hear this and go, oh my God, I must just dump them and go and find someone else. But have an honest conversation, because every relationship with your healthcare provider, your doula, whatever, it should be on a level playing field. And that means that you feel open to be able to say, how are you going to support me to have this feedback? And these are the things that are really important to me. So how will you support me to do that? And if you don't feel comfortable to have that conversation, then you don't have an equal relationship with that healthcare provider. Break that down. If you love your doctor, you have a really good relationship with them, well, start asking them hard questions and start asking them how they're going to best support you.
So I'm hearing like the moral of the story then with with our Mount Everest analogy and Olympic analogy and gathering your team. But the idea is, if you're planning to have really any birth after a previous cesarean section, does require a team that's on board with the woman's plan, even if that's to have an intended repeat cesarean section. So even if that is the plan to have a repeat cesarean section, the idea is to choose the people who are going to get you to the place you wanted to go, not where they think you should go. And so I guess the big message here for women who have had a previous cesarean section is really heavily explore and discuss this with potential care providers or your current care providers. And then if you've found yourself in a situation where you've got a care provider who you feel might not be completely on board with your plan, you could do a little bit of a rescue mission, I suppose, and try and sort of plug gaps with other people in your team, like a doula, like tap into the sisterhood of other women who have had vaginal births after cesarean section, because there's a massive knowledge base for women who have done it themselves, who can actually go in as a hero for you in a time of vulnerability and to bolster you and give you that pep talk, you know, at the finish line of like, we're going to keep going, we can do this, even if there's adversity. So
yeah, peer support was something that definitely came up as important. And we do have some amazing, one of the benefits, I guess, we've got social media is that it doesn't have to be people in your local community. You can catch up with people all over the place. We've got in Australia, the VBAC Australia Facebook page has got thousands of women on there, which means that any time of the day or night that you've got a concern, there's probably somebody feeding their baby and looking at their social media. So, you can reach out and you get that support straight away, and women stay on that. There's a real ripple effect of VBAC that we can talk about later, but one of that ripple effect is they want to support other women. And if that's even being on those support groups to provide that for women going through, it's a really vital part.
I just want to say too, around you choosing your care provider and having those conversations, one of the things that I get a lot of people to ask themselves is, do you feel intimidated by your care provider, or do you feel so soft and mushy that you could ask them anything? And so that's really really take that away with you and go, do I feel intimidated by them? Because if you can't ask them the hard questions and you feel vulnerable around them just in your pregnancy care, how are you going to feel in what is one of your most vulnerable states, which is labour and birth? If you can't speak up for yourself in pregnancy, you are not going to be able to speak up for yourself in labour and birth.
The essence of all of this continuity is that it's relationship-based care. But I do also want to step in for those that maybe didn't have a great relationship. So maybe they did find someone that was going to be their doula, or someone's going to be their private midwife or MGP or doctor, and they then felt that they just didn't click. They just didn't have that relationship. And it's actually okay for that to happen. That doesn't mean that it wouldn't then move, still carry on and there'll be great support for you. And maybe it's just not that, kind of soft feeling, but it's relationship-based care. And we know, certainly when we go dating, right, like they might sound great online, and then when you meet them, there's just no chemistry, so you don't really bother. But it's not the same kind of chemistry you're looking for, absolutely, but you might not click with that person, or there may be a problem in that relationship later on. So don't feel at fault when that can happen, because the basis of this is relationship-based care, and relationships have got to be two-way. There's got to be respect both ways, both from the woman and also from the healthcare provider, and give and take. And sometimes you could be let down by that person in relationship-based care.
So Hazel, my next question is, I've decided I want to plan a vaginal birth. My previous birth, I had a cesarean section. I've just discovered I'm pregnant. So what do I do now?
Well, I think first of all, every woman will have a bit of a plant growing in the back of their head that happened after the previous cesarean. So what were you told straight after that cesarean? Were you told at the time that never have another vaginal birth, or you can have a VBAC from the doctor's team or from the supposed debriefing? That has actually planted a little seed in there. And what you don't realize is that's actually been growing the whole time. So these kind of decisions don't happen when you get that pregnancy test. It's actually been growing the whole time. So kind of being aware of what's in your mind, what's in your head, and then grow your knowledge around that so that you can discern whether that little plant that's been growing, is that a weed or is it a really beautiful plant that you want to keep going? And knowledge is power. So you then need to really go on that journey of, well, where are you going to get that knowledge from? It can be from from a peer support group, it can be from books, it can be from reading research articles, whatever you like to get that information from, because that what I have found in the research is that knowledge that women get is really important. But it actually is also a challenging journey, because what it can do is it can highlight all the things that went not to plan last time. So a really important part of this journey is recognizing that women are coming from a place of trauma. So we know about birth trauma in the general population of women who've had a previous birth. It's about 1/3 of women. But in my VBAC survey, what we found is that was doubled. So 2/3 of women who'd had a previous cesarean found that a traumatic experience. And I think if we really understand that women are then coming from a place of trauma, that means they need support. And sometimes that trauma has gone all the way through to a diagnosis of postnatal depression or anxiety or PTSD. And then we throw women back into another pregnancy to do it all over again. So that trauma really needs to be explored. And so whether that's you've had a chat with someone who is experienced in understanding traumatic birth and help you unpack that, or whether that's with your care provider, it's something that will need to be done at some point. What happened last time? Really review what happened last time with someone who you trust, who can then see if there is some of your behaviours or thought patterns that could impact it. Because if you don't unpack what happened last time, it will come up. And when you don't want it to come up is when you're in labour, because then it will just be sending out the wrong hormones. As you all know, like, we want that oxytocin-rich environment when you're in labor. But if you're getting triggered, or if you're getting flashbacks of what happened last time, that is not an oxytocin rich environment. You're just going to start disrupting that hormonal cycle, and then potentially there could be problems with your labor. So wherever you've had trauma, it will come out, and it's better to unpack that, debrief that during your pregnancy, and also then kind of plan what is it that you want to happen this time, and be aware of that, and then choose the best place and people to support you on that journey.
And I just want to go back, because we mentioned it at the start, talking about place of birth, but I think a lot of people don't realise that there may be more options available to them than they're aware of in terms of where people planning a vaginal birth after cesarean can birth. So do you just want to talk about that a little bit more in depth?
Well, my first study I ever did before my PhD was a master's on exploring women's experiences of planning a VBAC at home. And I came from a background of planning a VBAC at home, although I transferred into hospital. And I also was a private practicing midwife supporting women. So I kind of wanted to know what was going on with women who were planning a VBAC at home. And I found a few things out. And what I did find is that women didn't always plan a VBAC at home at the beginning. It wasn't always like, I'm definitely going to have a home birth. It was a journey of often being pushed out. So women would go to a hospital and say, look, I've had this previous traumatic birth. I don't want a CTG. I don't want this. I don't want that. I know about the cascade of intervention. This ended up in my previous birth experience. Can I negotiate this? Can I negotiate monitoring? Can I negotiate being active? Can I negotiate access to water? And then, because of the impact of policies and maybe healthcare providers that aren't being so supportive, they'll say, no, this is what we do. You do it our way, or you go away. It's our way or the highway. And that actually backed them into a bit of a corner, and made them really look at what is out there. And because we have access to social media these days, you're actually able to explore, and maybe they found a private midwife's phone number, and I am sure Mel has had many of these phone calls like I have, and then they pick up the phone and they speak to a private midwife, and they share everything in that first phone call, and then say, could I do this at home? Would you support me? And the midwife says, yeah, that sounds great. I think you can have a great home birth, and I'd be willing to support you. And that could have been the first yes they'd got on that journey. Because all they'd heard before was no. And then they get a yes. And then actually what they do find is someone who's really, really supportive. So that's kind of what I explored. What does the evidence say about VBAC at home? Well, it's kind of variable. We do know that VBAC at home has higher VBAC rates. Even if they then transfer to hospital with the midwife, they still have higher VBAC rate. But things can happen with a VBAC. And obviously the biggest risk is uterine rupture. It is extremely rare, about 0.22% chance of it happening. And even if it happens, it doesn't mean that it's going to end in the death of the baby or the mother. It can, but usually 10% of babies that happens to, 90% of babies could even survive that. But what helps along that survival is getting to hospital and being able to have emergency treatment. And so where there isn't good collaboration and good pathways in and delays, then that could be an issue. And certainly in a study from the US, I can't remember the numbers off the top of my head, there were slightly higher rates of neonatal issues or issues with the baby. And when they looked at that, it looked like it was because there wasn't a very good transfer. There was like delays. There wasn't good communication between midwives and the hospitals. So I think if we look at that seamless transfer, make it better, then potentially there could be less issues. But on the whole, it's very rare for that to happen in the first place. Obviously, when it does, especially if it's at home, it gets media attention, it gets out there, and people get very nervous. But I will add, our privately practicing midwives have to do the highest amount of training, the highest amount of continual professional education out of all of the nursing and midwifery that is out there. They have emergency equipment with them. And we do also know then that women birthing at home, planning a VBAC, have a higher transfer rate to hospital. Now, I don't think that's a bad thing. I think what it shows is that midwives are being vigilant and aware and transferring early if needed, but they still have higher VBAC rates.
And that's the interesting thing. And so even for women who are not planning a home birth, just by hiring a privately practicing midwife, you actually can get the beneficial stats of above 80% possibility of having a vaginal birth, regardless of if you're at home or if you're at hospital, if your care provider is a privately practicing midwife. And that stat that you mentioned, 0.22%, is 22 women per 10,000. So that's the stat. 22 women per 10,000 births will experience a uterine rupture in labour with their next baby after a previous.
Yeah, I mean, the stats vary. Obviously, every study will come out with a different one, but it varies around, but it's generally below that 1%. Then what's really important is, well, what happens with that? And certainly I write about that in the book, and I break it all down to actually what occurs even if a uterine rupture does happen, because it's often given as a coercive tactic that if you do this and have a uterine rupture, this will happen to you. And it's seen as very fatalistic. It's the worst outcomes that can happen. But actually, we have one study, the ENOS study, that looked at a multi-center, multi-country across Europe, and looked at around 700 uterine ruptures that occurred. It was 800 in total, but 750 or something from previous cesarean. Looked at their outcomes, and that was a really interesting study because we hadn't had something that looked at so many, because it's so rare, to actually look at the outcomes of the uterine rupture. And I go into that in the book for women to really demystify it, because uterine rupture is talked about all the time as the biggest issue, but what is not talked about are the risks of multiple cesareans, which are just as significant.
Okay, so what I'm hearing then is that women who are planning their next birth after cesarean section really need to be selective about their care team, and just agreeing to or accepting standard care is less likely to land them where they want to be at the end with their ideal birth scenario. So being really conscious with selecting a care team, it seems as though from research and women's experience and what you're learning, Hazel, is that the best bet is privately practicing midwives in terms of a vaginal birth, if that's what you're aiming for.
I would say continued care with a midwife. I won't go all the way to privately practicing midwifery, which has a lot of amazing benefits, but only because there is that cost with it. So I would say continued care with a midwife.
I love that. Thank you. So continuity of care with a midwife. So that means having your own midwife, either one that's allocated from a hospital in a continuity of care midwifery program, one that you've specifically chosen. Basically, if you have midwifery care, you're going to increase your chances of getting the type of birth you want. Then obviously you need to grill that person in particular about how they feel about VBAC. And then that will tell you what kind of coach you've got. And I have worked with and seen obstetricians who are incredibly supportive of VBAC. I think it's a great tip, Hazel, talking to other women who have done it, because often women have already explored every pathway and can tell you the ones with the greatest success. Basically, the widest pathway is the easiest to travel to get to the journey where you want to go. So step 1, choose a great care team. The next thing I want to ask about, Hazel, is there seems to be a lot of fear language about planning a vaginal birth after having had a cesarean section. Can you talk to us about what the risks of vaginal birth after cesarean are? And then we also do want to talk about the benefits. So let's first talk about what care providers are concerned about with vaginal birth after cesarean and things that can be done to kind of mitigate the risks of VBAC.
So most women are well aware of the term uterine rupture because it gets used and they're told about it all the time. I will add they're often not told about the risks of multiple cesarean. And I do go into that in the book. I've got a little table in the book that looks at what the outcomes are and what the risks are for each one. So certainly you can go into that. And I've also broken down really what the biggest study that we've had out there, which was looking across Europe with 2.5 million women, and then only the 800 from that who had a uterine rupture, and then another about 100 drop who actually had a previous cesarean. So also, uterine rupture doesn't always happen for women who've had a previous cesarean. It can be for other things like having had lots of babies, or maybe trauma, like direct physical trauma type of thing can occur with a uterine rupture. But so then there was about 750 of them that had a uterine rupture after having a previous cesarean. And then I really break down in the book what actually happened, because uterine rupture isn't a full stop. Like, it doesn't mean it just ends there. Like, what happens, what were the outcomes of uterine rupture, both on the mothers and on the babies? And so I break that down in the book to really give women an understanding of, first of all, what is uterine rupture? What does that mean? And I go into all that detail, what actually happens at that time. But then I go into what are the rates, what are the numbers, what are the outcomes, and then even what are your options if you've had a uterine rupture. So one other thing I love doing in my book was I actually reached out to women and asked them to share stories that I could put in the book. And I wanted it to be, they planned to be back, but they had something different about them. So I reached out. I had 15 women across 4 different countries who shared their stories, and one of those stories is about a VBAC after a uterine rupture. So there's even that story in there to really give an idea that life does happen after uterine rupture, and even birth can happen after that. So often it's used, especially in a coercive care, that uterine rupture, that's it, that's the end of everything, and everything around you will just stop. But actually life still goes on after that, and what does that look like? So that was a really important part to put in the book too.
Can I ask, Hazel, can we break down uterine rupture a little bit? Because it's sometimes sold to women as you either don't have a uterine rupture or you have a complete uterine rupture. But there are stages.
Yeah, there are. So there's partial or complete. And the partial ones are a little bit tricky. So in previous research, in older research, they would put partial and complete together, and so which would kind of bump up the uterine rupture rate. But a partial one is, and I'm not a surgeon, I'm not an obstetrician, so this is me reading this as a researcher. A partial uterine rupture is where there's maybe an opening across the scar. But it may have also healed that way. So our bodies are really quite strange plus amazing. And sometimes when a wound heals on the inside, it might actually leave a little bit of a window. But that's not a problem. It's just the way it has. And then when you go to have a cesarean, they open up and they see that potentially could have been classed as a partial uterine rupture, but actually wasn't leading to one. It's just it has really thinned out and looks like it's going to. So partials are that kind of, it's starting to open. We don't know if it was going to open the whole way to a complete one, but a complete rupture is where you've had a complete rupture across with a previous cesarean across that scar line, or it may have extended past that scar line as well. Mm-hmm. And then there'll be different stages of what happens to the baby. What is the biggest issue is the baby can then come into the abdominal cavity, and obviously we've got a lot of bleeding that happens at that point because we've got internal bleeding, and baby can have a lot of problems with the placenta potentially coming away, oxygen levels, lots of different things that can go wrong at that point.
And those partial ruptures, they can be missed, and discovered later or just not even noticed, and the birth actually still occurs.
Yeah, and they may have been just a natural healing process of the uterus as well.
Do we know how many uterine ruptures are complete versus partial, like percentage?
Well, it depends if they've looked at the numbers. I think in INOS they didn't bother looking at partial ruptures, they only looked at complete. So really it depends on who's doing the study and what their parameters are.
So one of the risks of VBAC is uterine rupture. What are the others?
There has been some studies coming out recently that have looked at and state that there are higher third degree perineal tears for women planning a VBAC. But I would really have a bit of caution with that. I don't look at it in the book, and that is because they don't state the birth position of women at that point. And I think it's maybe a bit of an overreach to say that women who've had a previous cesarean are going to have a different type of perineum from everyone else, and therefore this perineum is more likely to tear. I actually think we need to look at what is happening during the birth. That is more likely to increase that. And so what I do know when we did the VBAC survey is that the most common birthing position was lying flat on your back, legs in stirrup. And so as a midwife, I'm kind of like alert thinking, well, that's probably impacting the type of tearing that you're having. So,
and if we look at physiology, it's the worst position to be in terms of the pelvic outlet. So that's the part of the pelvis where the baby comes out. You've got the least amount of room when your knees are out, as opposed to your knees being in, regardless of what position you're in. So stirrup, when your legs are up in stirrups, automatically closes off the bone hole that your baby needs to come out of. I said bone hole there. Yes, I did say it because it is. It's a hole in the bone in the pelvis. Bone hole. Go for it. That's the new pelvic outlet name. The other thing that's happening in that space is the pelvic floor is not in an optimized lengthening position either. And so that's what we're talking about with third degree tears into that muscle layer. It's the pelvic floor muscles that are tearing. And so position is huge. The other thing that happens with people experiencing a vaginal birth after cesarean is their options are very limited in terms of what they can access. When we really look at, again, like looking at those limitations around women having VBACs, a lot of it is time limitations. They are very closely monitored. They're probably more inclined to have things like vaginal examinations. And
I think it's having a bigger picture. Which is why I didn't put it in the book, because I just thought, well, you haven't told me all that information. So, but really, if we're looking at VBAC or risks of VBAC, that's kind of one that has been bandied about recently and was mentioned, but I just want more information before I start saying that that's an outcome.
I've got an incredible personal story to this. It kind of the story came up when you were talking about get yourself a student midwife for continuity. When I was a student, I cared for this woman that was choosing a VBAC, and she had the most amazing vaginal birth, and she had a third degree tear. And this midwife I was working with turned to her and said afterwards, I bet you wished you'd had another cesarean. And, when you were talking about the comments that people get, it came to me straight away. And she turned around to this woman and said, no, this is the most amazing thing I've ever done. And afterwards we talked about it. And she said, what that midwife wasn't seeing was the wound breakdown that I had after my cesarean, and how that ended up with me back in hospital, and how I didn't breastfeed my baby because of that, and my baby getting an infection and ending up in the NICU. She just saw the tear and just straight away assumed in that moment, oh, I wish you'd had a cesarean. And it was as a student midwife and as a woman, that comment, it will never leave me, because it was just so awful to hear that.
Yeah. I saw that in the HVAC study too, because women would say that there were some women that had a third degree tear at home and then went in to get it sutured up and then came home again, and the attitudes they got at the hospital was like, oh, you failed, like you failed because you had to come in here and get this all sutured up. And the woman's like, I've just birthed a baby through my vagina at home. Like, there's nothing. This is a blip. They saw that bit as a mere blip. Why do you judge me on that part? because there's no failure here. I just came, I got it sutured, I got it cared for, and then I went home again.
Is there a slight increased risk of postpartum hemorrhage, or is that as nuanced as the third degree tear?
Well, that's interesting. And if you look in the book, I've got a table in there, and what it shows you is that it just jumps all over the place. So when I do the comparisons between VBAC and then elective cesarean and then emergency cesarean, because really there's 3 outcomes that can happen, and then it just kind of jumps all over the place. But often what has happened when research has been interpreted is that, remember when I was talking about, you have this one cohort of group of women that plan a VBAC, then you've got the group that plan an elective cesarean, then often the outcomes are then given just still in those 2 groups. But we know in that group of planning a VBAC, there'll be 30 to 40% of women, maybe more or less, who have an emergency cesarean. And their outcomes can be very different to if you've had a VBAC. But if they're put all together, and then you only compare those who planned an elective cesarean compared to those who planned a VBAC, and in that includes emergency cesarean, then that group looks like it's got worse outcomes. When you break it out into 3 different groups, so when you look at then at the outcome of VBAC, emergency cesarean, and elective cesarean, VBAC did better in all the outcomes. Then it was elective, and then it was an emergency. And we know that, like, emergency cesarean does come with some added risks, but it's important to separate it out. And instead of saying, gosh, you shouldn't plan for a VBAC because you could end up with an emergency cesarean, it should be, let's plan for a VBAC and do everything we can to help you have a VBAC.
So on that then, because the risks of planning a VBAC are always really heavily focused on when care providers are discussing things with women, but what I very rarely see discussed is the risk of a repeat cesarean section. So when planning your next birth after a cesarean, you can either plan to aim for a vaginal birth, or you can opt to have a repeat cesarean section. And I love what you said at the book launch yesterday, that either of those decisions, each of those women are just as deserving of continuity of midwifery care, regardless of the choice that you make for your next birth after cesarean. That even if you intend to have a repeat cesarean section, midwifery care will always see you fare better emotionally, socially, across all of the, the wellness measures that you can imagine. So I love that women who are planning a repeat cesarean section after a previous cesarean section still will benefit from continuity of midwifery care, regardless of what option they're aiming for. But so I guess it's important for women to understand that there are risks to aiming for a vaginal birth after cesarean, but then there's risks to choosing a repeat cesarean section. So can you give us a bit of a breakdown as to what the risk factors are of repeat and multiple cesarean sections?
Yeah, so the more cesareans that you have, then the more risk you've got of things like adhesions, which can lead to pelvic pain and ongoing pelvic pain, and that can even lead to more painful periods and other complications. There is a higher risk of infections post-cesarean, and then placental abnormalities, so placental adhesion abnormalities. What I mean by that is things like the placenta actually adhering to the scar, or having an abnormal adhering to the placental wall. So the more cesareans you have, you've got more chances of placenta accretion and other complications that involves in that, which make it difficult for the placenta to come away, which then can increase bleeding after birth. And they're not really spoken about as much, but they're most certainly, this is major abdominal surgery, and you're going into the same place, and those adhesions, people don't really talk about that pelvic pain that can happen to having repeat cesareans, and they just get worse and worse.
And I see this a lot in the work that I do around pelvic floor health. I think there's this huge misconception out there that it's vaginal birth that causes prolapse, and that's the be all and end all. What I'm seeing in a lot of the internal release work I do is the effect of adhesions, and a lot of the work that I do with women who have, finished having their babies, 40s and 50s, the back pain that they get, the pelvic pain that they get is deeply connected to their pregnancy and postpartum, but also to their cesareans. And I do care for women who've only had cesareans who have prolapse. And if you look at Anna Crowell's work from the UK, who believes that prolapse is purely around tension, this is where these adhesions come into play a lot, because so her work is that, where the adhesions are, there's scar tissue, and that pulls organs out of place, out of alignment, and that's where you get your prolapse symptoms and pain. So I think, there's this big misconception in our society that a cesarean is the easy way out, and I'm doing that with the speech marks because it's not, and that it's going to protect us from all these issues, especially around the pelvis.
Really, though, one of the things that gets missed as well is that once you've had that first VBAC, all your other VBACs, right, those rates when we're planning a VBAC, and say it's about 60 to 70%, once you've had that first VBAC, your chance of having a VBAC, or your rates are 80% plus, regardless of model of care. And what that tells me is actually that's got nothing to do with the uterus. Nothing to do with the uterus. That's all to do with the brain. And that's all to do with confidence. And the woman knows that she can do it. If the woman has experienced and knows that her body is capable of having a VBAC, and then it just has like a flow-on effect because everyone around her feels, I hate that term, when they go, she's proved her pelvis, or she's proved that she can have a vaginal birth, then they suddenly have more support for you for all your previous VBACs, all your subsequent VBACs with much higher rates of doing them. And, I kind of just always challenge people at that point, or what do you think is the most important organ at that point then? Because I don't think it's the uterus at that point. We're really looking at the brain.
I think a really important thing for people to know here too is that, there is that common misconception that you can only have a VBAC after one cesarean.
So I've got a chapter in the book. It was actually going to be just part of the evidence, and then it ended up being a whole chapter, which was, can I have a VBAC if? So there's a whole bunch of different things in there that I look at the evidence for, and that does include multiple cesarean. And certainly, yes, the answer is yes, you can have a VBAC if you have more than one cesarean. And I do give the most up-to-date evidence on that. But what I do say to women is, well, it's not easy though, not from your part, but from the support that you're going to get. If we've got, and we do have, like an Australian rate of, say, about 11 to 12%, drop 10% if you're looking at more than one cesarean. It's just harder to get your support team. You just get more and more battles. It just turns into this constant battleground. So it just makes it hard. Like, it's not as if you can't, and the research supports it. Even the American guidelines support it, but that hasn't trickled down to the healthcare workers.
It really demonstrates that theme again, because if you're having to fight in labour, then what hormones are there? They're not the hormones that enable you or facilitate birth, which is oxytocin. If you're fighting in your labour, that's adrenaline. That's not going to enable you to labour efficiently and effectively, really.
But that doesn't mean that you shouldn't go for it.
Yes. So what I'm hearing then, Hazel, is that there's very few women who could absolutely not plan a vaginal birth after cesarean section.
Absolutely. And really, the reasons why you would need a cesarean, other than uterine rupture, which we know is rare, the reasons why would be the reasons why anyone else would need to. Mm-hmm. So if you've got, like a placenta covering the whole cervix, and, you would then need to have one. And so there would be really there should be the same reasons that the other women would need to have a cesarean for. We're just not very good in the healthcare system at negotiating. And certainly when I do training with midwives, and I've designed, ACM got me to design a online CPD activity based on this, on the book, which I did, was supporting women. And in that, I challenge the midwives to look at what their biases are about VBAC, but also how to negotiate. And it's actually okay to negotiate. It's actually good, and it doesn't make you at risk of being reported. You might be at risk of being bullied by your other midwives or managers, but actually negotiation is part of that two-way. So if a woman says, I don't want that cannula in, then you go, that's okay. Because actually we've got really skilled people here who can put cannulas in emergencies. That's kind of what they do. That's fine. I was an emergency nurse for years. Like, seriously, we used to do it when people are crashing and put in an emergency, a cannula. And a pregnant woman, they've got the most beautiful veins in the world. Like, seriously, we can do it at that point. All those things that you actually can negotiate. Those fetal heart rate abnormalities we can pick up with a Doppler. it's actually okay to negotiate. But midwives get very scared because it's such a penalised system that if they don't follow a guideline, they're going to get into trouble. And the same with doctors. They're so penalised as well. And they've got a very difficult structure because they're bullied by their bosses.
So I just, because I really want people listening to this to know that they are allowed to negotiate, they are allowed to have choice, they are allowed to say no. And it's not just if you say no, then you're going to be punished and you have to go and now birth at home if that's not what you want to do,
Well, they get labelled as a difficult woman.
Yeah, but it's a human right.
But we also know obstetric violence exists in Australia. We've got the first paper coming out on the first paper on obstetric violence in Australia. And
amazing.
So we know it happens.
Well, that's the issue, isn't it? Is that women I wanted to have a VBAC, but everyone was frightened and nobody offered me the opportunity. And then there's coercion. And so there's actually going to be published research that highlights this pervasive issue of obstetric violence.
Yeah, for all women as well. That's coming out of the BEST survey. And it shows 1 in 10 women experience obstetric violence. 1 in 3 experience birth trauma, but 1 in 10 actually have obstetric violence. We've got a conversation article that's going to come out the same day. We've got a whole media release. It's going to be a big party. I'm quite scared.
Don't be scared. We'll pop it. We've got to get the word out there because this is the silent endemic thing that's going through maternity care at the moment is obstetric violence, and women keep getting silenced by people telling them that their baby and themselves are alive and so they should be happy. And it's wrong. And so there's all this focus on preventing 22 in 10,000 uterine ruptures for women planning VBAC, yet we've completely forgotten to have a look at the fact that 1 in 10 women are the victims of obstetric violence in Australia.
That's it.
And 1 in 3 have birth trauma. And it's higher for these women that we're talking about today.
Double. So Hazel said double. So of the women who've had cesarean,
2 in 3 women were having experienced birth trauma.
And this should be the most empowering event of our whole lives and should lead us into motherhood, which is by far the hardest thing that any of us will do with trust in our bodies and our minds' ability. And so many of us are getting robbed of that, and it's criminal.
So proud of you for not swearing just then, B.
Thank you.
Yeah.
And what I didn't mention is Hazel and I work together at Western Sydney University, and we're currently working on a project, the birth in the time of COVID. So I've completely left that out. I forget to tell people that kind of stuff.
Yeah, that's a pretty cool study we're on. So that and then the BEST survey.
Amazing. And B, I'm adding a word to your B-ism dictionary. Bonehole is now added to the B-ism dictionary.
Bonehole should just be added to the dictionary, just in general.
Magic. Oh my gosh, that was Birth After Cesarean with Dr. Hazel Keedle. And if you're on the mailing list, you get an opportunity to win her book and to have access to all of the resources that we mentioned today in this episode. We will see you next week in episode 8. Bye.
Thanks for listening with us today. Don't forget to subscribe to our podcast on your favourite podcast platform and join our mailing list at melaniethemidwife.com. Mel sends out weekly emails with access to all the evidence we use in this podcast. You can find out more about Mel at melaniethemidwife.com and find out more about me, B, at coreandflaw.com.au. We can't wait to bring you next week's episode of The Great Birth Rebellion. Yeah!